This program is brought to you by Emory University.
Good morning, everyone, and happy Friday. Thanks for joining us today for this Friday's Fellow Conference. Today we have Scott Gaignard, who is one of our second-year fellows. Scott is originally from Louisiana and did his medical school there. He came to Emory for residency, and we've been lucky to keep him on as a fellow as well. And so Scott is going to be talking to us today about pericardial effusion. It's all you, Scott.
Thank you, Dr. Coley. Good morning, everyone. I have a good case and just overall topic discussion based on some of the cases I saw over at Midtown this last month, particularly dealing with pericardial effusion. So excited to share and get some expert opinions on this. So objectives are pretty simple. We're going to walk through a case of cardiac tamponade together and then review some guidelines on non-inflammatory pericardial effusions, and particularly hone in on the most recent literature of chronic idiopathic effusions. So to get started with our case, we have a 46-year-old woman that presented to the emergency department via EMS for complaints of chest pain and shortness of breath for a few hours. Some pertinent positives: the chest pain started in her left chest, radiated to her jaw and throat, was associated with 4 episodes of vomiting, and she was sitting at home. She wasn't doing anything strenuous beforehand, and she's also an active smoker. So some signs of typical angina there. Her past history is mostly related to her CKD. Unfortunately, she was following closely with nephrology. She had progression of her CKD to near dialysis levels. This was presumed due to hypertension. And the most recent, in her last office visit, she was having some issues with adherence to her medications. And like I said, her dialysis concerns were growing in the setting of medication non-adherence. And 3 years ago, pertinently, she was also at an outside hospital where she had similar complaints. It was found to have a pretty large reversible ischemic defect on a PET scan they obtained there. But unfortunately, she refused any intervention because she was so worried about her kidneys. Her past history is minimal. She has CKD4, she has hypertension, hyperlipidemia, she has some degenerative disc disease in her back, obviously that pertinent PET scan as well. She also is an active tobacco user, and she's on a number of medications, mostly related to hypertension control and these patients with significant kidney disease. Vitals and triage EKG. She was actually normotensive when she arrived, normal heart rate. She was not febrile. Her EKG was, for the most part, pretty unassuming. There's no significant ischemic changes on her EKG, maybe some mild Q waves in the inferior leads, some poor progression, but otherwise nothing concerning for acute ischemia. Her initial laboratory values also were pretty unimpressive. She had an elevated BUN and creatinine, unsurprising for her. And then, surprisingly enough, her troponins were actually completely normal, both on arrival and the delta after 1 hour was only 15. Somebody with this amount of CKD, pretty unimpressive value. And her BNP was also very low at 68. Her first image was just a simple chest x-ray, as per usual. This was also pretty unimpressive. There's maybe some mild vascular congestion, but nothing really to write home about. Large cardiac silhouette, maybe an effusion over there on the left side, but nothing that really strikes us as particularly diseased. So medical decision-making for her, cardiology was consulted overnight, and the patient was dispositioned over to the CDU for a potential cardiac PET scan and further workup of the chest pain, especially in the setting of negative cardiac biomarkers and an unimpressive EKG. So unfortunately, around 6 a.m. that next morning, about 7 hours after presentation, things started to change a little bit. Right before she was actually going to go to the CDU, she had a large episode of vomiting, and her blood pressure was recorded as greater than 200/100 at that time. She was restarted on some of her home medications. Turns out she actually didn't take anything, which we see very commonly. She didn't take any of her medications before arriving to the hospital because she wasn't feeling well the night prior. Her BP luckily improved, and she had felt better. And I added a little bit of an addendum from the chart. It just said from the nurse that the MD was at bedside. They didn't have to give any additional IV hydralazine or any other medications. She was doing well at that point. Change of plans around 10 a.m. or 11 hours after presentation, but 4 hours after that event, HMS had actually come by to the ED to admit her to the floor for blood pressure monitoring and then further evaluation of her chest pain. She was no longer a candidate for the CDU given her high blood pressure. But unfortunately, about an hour later, a nurse came by to bring her to the floor, and she was very lethargic, very difficult to arouse, and she noted that she had a very weak pulse as well. So the emergency MD was called to bedside immediately. And unfortunately, changed the plans even further. The patient immediately lost the pulse as soon as the MD walked in. The rhythm was PEA arrest, and they started compressions and CPR. And luckily enough, after about 4 minutes, ROSC was achieved. As part of the workup, they brought the ultrasound in there and took a look at her heart. And surprisingly enough, bedside revealed a very large pericardial effusion. Um, Given she had just coded and we were lucky enough to get ROSC immediately, intravenous fluids were started, and interventional cardiology was also called. And given how quickly the CPR went, she actually did not need to be intubated. She was awake and alert after the quick code. So interventional cardiology came down immediately to bedside and tried to do a bedside pericardiocentesis due to the acuity of her condition. They didn't feel comfortable trying to get her up to the cath lab. And then here we have a single picture uploaded into the chart of what appears to be the pericardial needle actually into the pericardial space. But despite ultrasound guidance, they could not actually withdraw any fluid from the cavity. Given she was hemodynamically stable, she had no other evidence of any kind of instability. They decided to bring her up to the cath lab immediately to perform pericardiocentesis with fluoroscopy assistance alongside TTE assistance as well. And then under fluoroscopy and ultrasound guidance, they tried again with a micropuncture kit. And unfortunately, we're only able to get about 3 cc's of bloody fluid. We weren't able to get any more. They knew for sure they were in the space. And so they took a look at the echocardiogram. And sure enough, here's our parasternal long images. There's some striking things here, but just in short, she has a small LV cavity, significant hypertrophy, normal EF per the parasternal long images. And then as you could see, a very much struggling RV, and then what looks like on top of it, not only pericardial effusion, but some kind of highly mobile, either bloody thrombosis or something in that pericardial space that's not just simple fluid. And again, you can see on this other side of the parasternal long view as well, there's some kind of adherent material attached to the RV. It is quite large in this dimension as well. It's over 5 centimeters. Here in our subxiphoid view, again, you can see the liver there, and then just a highly mobile mass floating around in that pericardial space. And then the subxiphoid view with the IVC here, you can see that the IVC is not very collapsible at all. And the M mode kind of further confirms that the IVC ended up being about 2.2 centimeters and not collapsible. And the view I think I like the most is this parasternal short view, which will view a few of these images. You can see a very much struggling RV on top of this mobile mass. And the LV looks like it's actually functioning pretty well in this instance, has normal EF. And then this apical 4-chamber view that they got showed this large mass kind of completely covering the RV over on that side in the pericardium. And then our M mode parasternal short view as well shows pretty impressive RV chamber collapse, both with inspiration and expiration. And then here in this parasternal view, you can actually see that collapse as it's zoomed in on the RV. So the RV is definitely fighting for its life with this pericardial effusion. They ended up reading the final read for the echocardiogram showed a pericardial effusion obviously there, and then at least echocardiographic concerns for cardiac tamponade. The IVC was not collapsible as we talked about, and then the RV was struggling with respiration and had significant variation. And the size of the mass is pretty impressive. It was over 10 centimeters. That's greatest length and consistent with thrombosis. So with that in mind, interventional cardiology immediately consulted cardiothoracic surgery for pericardial window and further evaluation from there. The patient was prepped, sent immediately to the OR, and they decided to go ahead and move forward with a small pericardial window. Given the unknown etiology of the effusion as well, they went forward and did a TE there in the operating room. And here I have just an example of what they would be seeing when they created a pericardial window. Once they made that pericardial window, there was a large amount of blood that was expressed. It was gross blood. There wasn't mixed. It wasn't serosanguinous. It was true blood. And then sure enough, the operating room TE showed, as you guys can see here, aortic dissection right there at the right STJ. She had no symptoms of this before. She had that episode of chest pain, but otherwise there was no ripping back pain, ripping chest pain. She had that episode of severely high blood pressure, but there's no other, at least clinical evidence until we really saw that TTE that she had something like a dissection. But the TE kind of confirmed that. And luckily enough, we found the etiology is a large aortic dissection originating in the right STJ. Here with the aortic valve, they did an X-plane there as well. You could see some mild, at least mild aortic regurgitation there, and you could see the aortic dissection as well in this view. Again, here's another view of that aortic dissection in the false lumen there. And then interesting, there's a nice aortic run through here, and you could see the dissection plane kind of come into view as they run through and come back out. The final read of this operator room TE showed an aortic dissection extending from the right STJ in the ascending aorta all the way through the distal aortic arch. Luckily for the patient, there is no dissection flap visualized in the sinus, and the right coronary was uncompromised and safe. And then obviously she has a very large pericardial effusion as well. So in the operating room, they went from just a pericardial window and a TE to a emergent type A aortic dissection repair. But luckily found the etiology of this large pericardial effusion and the hematoma inside. So cardiothoracic surgery proceeded with the ascending aortic repair using a gel weave graft and cardiopulmonary bypass support as well. So the final diagnosis for our patient was cardiac tamponade secondary to aortic dissection and pericardial thrombosis. The theory of this thrombosis is that it actually contained the dissection and stopped further fluid accumulation into the pericardial space. And the pathology is a little bit of two. There's both this probable theory, and then also there's actually transudation of the fluid across that thin false lumen as well into that pericardial space. There's a significant amount of leakage due to the very thin adventitia of the false lumen. Well, luckily for the patient, it allowed for a very precious time of hemodynamic stability while our teams mobilized and eventually found the culprit lesion of why that thrombosis was there. And again, luckily enough for the patient, the dissection did not extend to any of the coronaries. So overall, in this case, she actually did very well once the aortic dissection was resolved and repaired. She was able to leave the hospital. And besides, unfortunately, she did advance to ESRD in the setting of this, but this is really the only complication. She would go home to her family. So some important points about this case. This case isn't the sole reason for the talk, but cardiac tamponade with aortic dissection is a very poor prognosticator and is one of the most important risk factors for poor outcomes for aortic dissection. And in-hospital mortality is actually very impressively high. It's over 54% for type A aortic dissections. I think for tamponade, it's less than 20%. But for aortic dissections, it's over 54% when it's associated with tamponade. So very, very high. So identification is very key. And there is actually some controversy regarding the safety of pericardiocentesis with aortic dissections. This can be a whole talk in and of itself, but the theory is basically that if you were to remove the fluid from the pericardial space, remove all that blood, it creates almost a suction-like event, which can further propagate the dissection and cause more issues and reaccumulation of the fluid or worsening the dissection. But there's been various studies that have actually shown this might be safe. And if it needs to be done to get the patient to the OR, it should be done. So pericardial thrombosis differential, especially for my co-fellows, is there's really only three things. There's either aortic dissection, which is in our case here, there's free wall rupture, or there's cardiac trauma. And this is a diagnosis of exclusion. You have to exclude these three things before you can really move on and say that mass that we were previously calling it is anything but thrombosis, and it must be investigated immediately, especially in the setting of aortic dissection. The chances of in-hospital mortality when the patient's stable is 54%. If the patient is unstable, I believe it's close to 80%. So it's a very, very, very high mortality diagnosis and needs to be found immediately. But for every case of tamponade where we feel like we know what we do, there's a lot of cases of pericardial effusions where we don't. And so we just reviewed a case where cardiac tamponade was identified and had just about every piece. It had a pericardiocentesis, it had a pericardial window, and then for our patient, she ended up with an aortic dissection repair. But for a lot of pericardial effusions, without tamponade, there's a lot of shade of gray. And I saw another patient in the unit that came from an outside hospital, where she was worked up for a large pericardial effusion. We didn't find an etiology, and she was hemodynamically stable. She had no signs of clinical tamponade or echocardiographic tamponade, and we let her go home. And that kind of struck a chord in me, and I kind of asked myself, well, what happens to these patients? Where do these patients go where we send them out with these large effusions? Do they do well? Do they not do well? Or to really have any idea of what happens to them besides, we just quote unquote keep an eye on them. So I wanted to explore that more. So again, in our world of effusion management, there seems to be only one truth, and that is if they show signs of clinical tamponade, it is probably best to perform invasive drainage. So tamponade equals a drain, more or less. And I say probably because there is not a ton of literature out there in terms of good randomized trials where we know that pericardiocentesis is the best thing. But we do that based on limited data and to stabilize patients. But for just about all patients, like I said, we don't have a great sense of what to do next. So really quickly, just through some basic histology and anatomy. The pericardium comes from the Greek word around the heart and contains two layers. It contains a serous viscous layer very close to the heart, the epicardium, and this fibrous parietal layer. And the pericardial fluid lies between the two. I just added a gross image here as well to show you the extensive nature of the pericardium that we see here. The etiologies of diseases affecting them are quite vast. When we see patients in the hospital, we think of infectious causes, usually number one. It's kind of the first thing that we really rule things out. We commonly think that viruses cause pericardial effusions. There's bacterial, fungal, et cetera, but there's more. There's autoimmune diseases such as lupus. There's amyloidosis. There's aortic dissection that we saw. There's metabolic problems such as uremia. And there's also things like trauma and iatrogenic, either from cardiac surgery or blunt trauma. There's even drug related, which they label as quite rare. And there's a long list of drugs here, including amiodarone, which until I did this talk, I had no idea this could theoretically cause a pericardial effusion. But the etiologies of them are just incredibly vast. But unfortunately, there's no guidelines from the ACC or AHA regarding pericardial effusions. The only guidelines we have actually are from the ESC, and they're back in 2015. And even these guidelines mention a pretty clear lack of concrete evidence of what to do with large and chronic pericardial effusions. So if we look through just a snippet of these recommendations back in 2015, the evidence level is only C. There's really nothing better there. It's a class 1 indication, but there's really only level C evidence. We look through a few of these, you can see just how vague they are. And, the first recommendation is it is recommended to target the therapy of pericardial effusion at the etiology, which could not be more vague. And then if we look at the bottom, it says pericardiocentesis for tamponade is indicated, but for large effusions, not responsive to medical therapy, which we know is commonly not. You should consider performing pericardiocentesis for these patients. And again, there's really not great evidence since 2015, and I was curious to see what else is out there. Do we make any great strides? And again, we know what to do about tamponade. They have a nice, convenient chart in the guidelines that say if you have tamponade, yes, go ahead and do a pericardiocentesis. But as we go further down this chart, we end up finding that we know less and less about what we're actually doing and if we're really helping the patients. And I really want to focus on these patients down here, the ones with large pericardial effusions. They're non-inflammatory. They never had tamponade, and really look at some of the new data to see if we're taking care of these patients properly. And I went into this research thinking that we were probably not being aggressive enough about these patients. And I was curious if there'd really been any insights in the past 10 years since the ESC released their guidelines. And I have 3 papers that I will quickly go over. This first one has quite a long name, but it was done in Greece. It was post hoc analysis completed back in 2020. And the study was small. It was only 74 patients. They followed them for actually 2 years, however. And their question was simple. These patients with large idiopathic effusions who did not ever have tamponade, what happens to them after they undergo an invasive procedure like a pericardiocentesis? And these guys did an absolutely excellent job of ensuring they were truly idiopathic. They performed a great workup to exclude really any possible past history or acute infections or any other diseases such as cancer that could have caused a pericardial effusion. So as you can see here, the exclusion criteria was actually incredibly strict. You could not have heart failure or even pulmonary hypertension ever diagnosed. You could not have any history of autoimmune disease. Obviously, couldn't have acute pericarditis. They did additional imaging, and actually, some patients even underwent cardiac MR as well to ensure this was an idiopathic effusion. And here on the left, we see a table which just kind of compares a pericardiocentesis patient to the surgical drainage and then the conservative patients there. And sure enough, there's no significant difference in the baseline characteristics, especially in terms of the size of effusions or what they underwent. And we see here that unsurprisingly, pericardial window outperforms a pericardiocentesis in terms of reaccumulation free survival rate with this logarithmic graph. So it's overall better, at least from a reaccumulation standpoint, to move forward with a pericardial window than it is a pericardiocentesis. And more importantly from this, I found that the fluid reaccumulation rate was really the most impressive thing. And invasive treatment with the pericardiocentesis actually led to a much higher fluid reaccumulation rate in the majority of patients, much more than the pericardial window patients or in the patients that had nothing done. And the question that should kind of come to mind is, do these patients just have some form of predisposition to accumulating pericardial effusion? Is there some kind of disease that we have yet to diagnose or yet to understand fully that's causing this? Or, do we create the problem? Do we introduce inflammation to the pericardium and then cause a higher incidence of fluid reaccumulation? And then, of note, in the conservative group, 17 of those patients remained completely stable during follow-up, and only 2 progressed to clinical tamponade over the 2 years. So those that were really left alone, overall, they did quite well. So the question for the paper is, what happens with these patients with large pericardial effusions that do not have tamponade, do not have symptoms, and underwent invasive procedures? In this analysis, they did well if you left them alone. If you didn't, fluid reaccumulation was quite common for the non-surgical interventions. And overall, at least from this paper, we should maybe think about not offering routine invasive drainage via pericardiocentesis if these patients are doing well. The second study comes out of Italy. This one's a little bit more patients, but only 100, which is tiny in terms of cardiology research. Yeah. Hello. Oh. The median follow-up was 50 months. And the question for this was the outcomes of these patients diagnosed with non-inflammatory idiopathic pericardial effusion. What happens to them? And the authors were a little bit looser in terms of the past medical history for idiopathic effusions, but they did a good job of ruling out serologies and other imaging modalities before they went forward and entered the patients into the study. But unlike the previous article, 66% of this population had symptoms and presentation, typically shortness of breath, instead of the completely asymptomatic group in the study we just looked at. Impressively enough, of the patients with large pericardial effusions, as we see here in this graph, it just shows the size of the effusions at baseline and the size of the effusions at end of the follow-up over the 50 months. And pericardial effusions generally regress in size. And actually, in 39 of those patients, there was complete regression. And then over here on the right, we actually see an event-free survival, recurrence or complications in patients with pericardiocentesis with or without any intervention. And the intervention-free group outperformed the intervention group in regards to survival-free events. So again, this kind of further supports not intervening on these patients. And what I really liked about this study is they actually separated the patients that had symptoms from the patients that didn't have symptoms. And symptoms or not, there was no change in prognosis or progression to cardiac tamponade, which I think is very important for us because I think we like to act on symptoms in cardiology, and the fact that symptoms did not matter in terms of their overall prognosis is an important signal. So again, here's our current study. It kind of compared to an older study done previously, and it found that the median time to tamponade was 38 months. So there's quite a range there, but it was many, many months, over years, to actually cause tamponade physiology. And then only 8 patients, or 8% of the study population, actually progressed to cardiac tamponade. And for various reasons, 30 patients underwent pericardiocentesis. And what I really liked, again, with this study is that of those that underwent pericardiocentesis, cytology was completely unrevealing and no new etiology was found in all cases, which means that if there was a large workup done before, a comprehensive workup done before, it seems like it actually drawing the fluid and undergoing testing with the fluid doesn't end up giving us a new diagnosis. So for this study, again, it was a small prospective study, but patients with chronic large idiopathic effusions tend to do better without intervention, just like a Greek study showed. And in most cases, your effusions actually go away over time, regardless of the symptoms that they may have. And then with a negative comprehensive workup, like I said, there also seems to be no real diagnostic utility to undergoing cytology and further workup of the pericardial fluid from pericardiocenteses. The last study we'll look at is a pretty new study. It was finished in 2024 as a multi-center retrospective cohort study, again done in Italy. There's 124 patients here, and the follow-up was a little over 2 years. And they asked again another question of, what happens to our patients when they undergo invasive pericardial procedures for these large chronic idiopathic effusions. And they particularly define post-cardiac injury syndrome as more or less pericarditis, signs and symptoms of pericarditis 1 to 6 weeks after pericardial intervention. This population, as we could see, was a little bit more heterogeneous compared to the previous 2 studies. These patients had previous MIs. Some of them had kidney disease. Even some of them had cancer. And so it was a little bit more of a heterogeneous population, but the study authors felt comfortable calling the pericardial effusions idiopathic. And it took the 124 patients who underwent pericardial effusion drainage. 110 of them underwent typical pericardiocentesis, and 25 of them underwent a window, and 1 patient ended up getting a pericardiectomy. 20 patients had defined post-pericardiotomy syndrome within those 6 weeks, and then over 29 months, 75 patients had recurrence of their pericardial effusion as well, which is very, very important for these 2 things. And of those 124 patients that underwent intervention, 75 of them had recurrence, 20 of them had PCIS, like I said. And overall, that's 77% of the population that underwent this intervention ended up having some form of complication or unfavorable outcome. If we break these down even more, we see that the pericardiocentesis leg of this, which is by far the largest leg, had the most number of recurrences and the most number of post-cardiac injury syndrome. And the authors asked, well, what do we do? What if we do a multivariate analysis and see of everything going on with these patients? Is there anything that typically predicts pericardial effusion recurrence? And the only thing that really ended up having anything of significance was the fact that they got a pericardiocentesis. And that was it. The only factor that correlated with recurrence was pericardiocentesis itself. So in this small study, again, invasive drainage of large chronic pericardial effusions was associated not only with recurrence, but maybe post-cardiac injury syndrome as well. And this is mainly seen in the pericardiocentesis leg. So again, these aren't, these are not clinical trials. They're not randomized. They're not very large, but it's the best we currently have. And, the question should be, for these non-randomized trials, are we moving the needle ever so slightly in our understanding of, are we really helping patients when we do pericardiocenteses? If we review these in the first Greek study that we saw that in large effusions, pericardiocentesis tend to not be beneficial and they tend to recur. And then in the Italian study, these large effusions, pericardiocentesis, tend not to be beneficial, and many times effusions resolve on their own. And then in the Italian inflammatory or the PCIS study, recurrence is very common post-pericardiocentesis and may even cause a predisposition for inflammatory disease and may open the patient up to pericarditis as well. So when we look back at our recommendations, I kind of question this last box here, and it says for moderate or large pericardial effusions not responsive to medical therapy, which they really never are, And for suspicion of unknown bacterial neoplastic etiology, you should move forward with a pericardiocentesis. Now, obviously, if you have a significant concern for neoplastic disease or bacterial disease, you need cytology, you need that. But for patients that have no diagnosis of that, it may not be worth moving forward with a pericardiocentesis. And despite the safety of these procedures, complications rates are usually less than 1% in the perioperative period. They seem maybe not to be worth it. And again, if we look at this flow chart here, once we get down to our patients, I do kind of question whether we should even consider pericardiocentesis and drainage if chronic. If it's solely chronic and greater 3 months, at least from what we saw of these trials that ended up being multiple years, there really is no great role for pericardiocentesis. It seems not to help these patients, and recurrence is so common. So in conclusion, pericardial thrombosis is a diagnosis of dissection or free roll rupture until proven otherwise, and this must be investigated immediately. It really bodes the fact that if you see thrombosis or any concern for thrombosis inside the pericardium, a TE needs to be done, a CTA needs to be done in order to ensure no dissection. And then our advancement of our understanding of large idiopathic non-inflammatory pericardial disease has been rather minimal. Ever since the 2015 guidelines have come out, there hasn't been a whole lot of movement forward. These studies, I think, offer us a little bit of insight, but not a lot, obviously. The signal points, though, to pericardiocentesis not being very helpful from a therapeutic or a diagnostic purpose. And I really think when we get these consults, when we see these patients, we should do our absolute best to discover the etiology of an effusion, to really push for a full diagnostic workup while they're in the hospital or when they see us in clinic to ensure there's no diagnosis and nothing that we can actually target. For the patients that we don't find an etiology for, and these effusions are truly idiopathic, they're left in an incredibly gray area, which is, for the patient, watchful waiting seems to be very safe, which is good, but we don't really know what we're doing with them. And so finding an etiology is always best. And just want to thank Dr. Dollar and Dr. McDaniel for kind of talking me through some of the slides and some of the information. And I really wanted to, with this fellow talk, kind of discuss this case, but then also with pericardial diseases, it's expert opinion, and I just wanted to kind of hear from the audience and from those that have been doing this for a lot longer than us, fellows, just what your experience has been and if it lines up with the data I presented. But thank you all for joining me on this Friday morning.
Hey, Scott, good review. This is Mahmoud Abdu. Thank you for, this is an excellent review. And I have a few comments really and no questions. And, I liked a few of your slides where you, especially the phrase where you said synthesis equals more or less to tamponade, or vice versa, tamponade equals more or less to synthesis. And I was waiting for you to land in the pitfall of saying size equals to synthesis. And that's usually sometimes you're very tempted to face and very tempted to do, is you see a large pericardial effusion, you say, you know what, I'm just going to put a needle in there. The reason why I bring this up is that a lot of cases with advanced pulmonary hypertension, you will be faced with large pericardial effusions that are there for months and years and years. And, the minute you start thinking about draining them, putting a needle in them, these patients fail miserably and go into cardiogenic shock and not do well in a very short period of time. That's another thing on one of your other slides where you said that one of the pitfalls of chronic pericardial effusion, is that it recurs. And not only does it recur, but if it happens in this particular clinical scenario, it can be devastating with bad outcomes. So good talk, good review. And like you said, it's all expert opinion. I don't think you'll have a lot of guidance on this, but it's always good to kind of, it's challenging even for me till today. I usually ask and ask around before we attempt anything, especially if the patient is stable with no signs of tamponade. So thanks, Scott.
Thank you, Dr. Abdu. Appreciate it.
Scott, Steve Clements.
Hey.
So maybe I missed the first of your talk, but it's important to realize that the pericardium reflects onto the aorta relatively high up. And that's how blood gets in the pericardium with dissection. Because 2 or 3 inches of the aorta are within the pericardium. So sometimes that's not appreciated. That's why you get pericardial effusions of one kind or the other. Of course, a bloody one means something is bleeding, maybe something is ruptured, but that's kind of the anatomic situation there with the pericardium and its reflection onto the ascending aorta. That's very good. I've been surprised through the years that even though we look for it, that constriction does not follow pericardial like benign viral pericarditis that we see, even with bloody pericardial effusions. I've been surprised that that's not been a sequence as often as one would think. And when we find a constriction, oftentimes it's advanced and been there for years, occult, and then finally they present with abdominal distension and big neck veins and all that. So it's always interesting to deal with the pericardial disease, and your approach to it sometimes has to vary depending on when it is. For example, seems like to me this is a common diagnosis on either Wednesday afternoon before Thanksgiving or Friday afternoon. So you have to plan for the weekend when you see that.
Right.
When they have multiple hundreds of mLs in there, and the weekend is there, and things change a little bit there. So thanks so much.
Absolutely. Yeah. The decision in the hospital to tap the effusions can be tricky. And like you said, if there's days in between, reliable cath lab coverage, I know we always pause and think really hard about whether we should move forward. And it could be tempting for sure. We're used to fixing things, and it's easy to fix, but agreed. Sometimes it's as tempting as it is, it may not be the best thing for the patient.
Another comment, say, if you look way back in the history of medicine here at Emory, you'll find some literature by Bruce Logue and Linton Bishop that tells us how to do a pericardiocentesis by using the pericardial needle without a wire. We have a much safer way to do it nowadays. And to connect that wire to V1. I don't know if you've ever heard of that. Sometimes the pericardiocentesis trays still have the little alligator clamp wires on there with alligator clamps on each side, which were intended for putting the needle in there and watching the EKG. When you do it, the SC segments go up, then you've hit the epicardium there. So that goes way back in the history of pericardiocentesis, and I think it spread throughout the country. And that was Linton Bishop and Bruce Logue's contribution to pericardiocentesis.
Wow. No, I did not know that. That's very interesting. Very cool.
Hey, Scott, this is Charlie Searles. I'm just wondering about medical therapy in these folks. I don't know if you mentioned that in those studies. Was there anything about, colchicine or NSAIDs or anything that they would use, or did these patients get anything like that?
So for at least for the studies, I believe there is some colchicine used for the last study with the pericarditis-like syndrome after pericardiocentesis. But for the vast majority of these patients, that was actually an exclusion criteria, that they couldn't get colchicine or NSAIDs or anything of that nature for the studies. And I think for these patients, I really wanted to kind of hone in on those patients, the chronic, the idiopathics, where we don't see any inflammation and there we don't feel the need to use something like colchicine. I know that if you go down the more of the pericarditis route, obviously, or the pericarditis with effusion route, you'll see more colchicine. But From everything that I saw, both of these studies and outside, if there's no evidence of significant inflammation, which is in the pericardial literature is as much as just an elevated CRP, then it tends not to be very useful in terms of medical management.
Stan Sherman's good talk. Did they subset the chronic renal failure patient like your patient was, and how many of these chronic idiopathic pericardial effusions ended up improving when they went on dialysis or anything like that?
They in the no patients had significant CKD. In the last study, there was a subset of patients that had some chronic kidney disease that wasn't severe. But in the first two studies, they more or less excluded those patients.
All right, well, if there aren't any other questions or comments, we'll end with thanking Scott for such a great presentation, and I'll see everybody next Friday. Thanks.
Thank you, guys.
The preceding program is copyrighted by Emory University.